Good afternoon, everyone, and welcome to TxRx Community of Practice Echo. Please note that we are recording these sessions for future distribution. Anything listed in the chat does not appear in the recording. Your name may appear in the recording, so please know that you can change your name to first name only if you would so prefer. My name is Shreya Prasanna, and I will be facilitating today's session. A few quick announcements before we begin. To help us with attendance, please enter your name, affiliation, and email into the chat, which can be accessed by clicking on the speech bubble icon on the navigation bar at the bottom of the window. If you are one of our Be Well Texas providers, please make sure that you identify yourselves during the session. If you're joining via phone, please email your phone number and name to bewelltx@utisca.edu. We'll drop this email address into the chat. Some housekeeping. Please stay muted unless you're speaking. If you join by computer, your mute button is the bottom left of your Zoom controls. If you're on the phone, just press *6 to unmute. We encourage everyone to speak at these sessions, especially during the discussion portion. We want to hear from as many of you as possible, so please keep your comments brief to allow time for others to speak up. Or if you'd prefer, you can use the chat feature to share your comments and questions. Please note that no predicted health information is allowed either in the chat or in the discussion. If you'd like to view closed captioning for this session, please navigate to the bottom of your Zoom window and select the Show Captions option. You may need to click on More at the bottom right corner of your Zoom screen to find this menu. If you're having trouble accessing captions, please message Echo IT. Towards the end of the session, the Be Well Texas team will send out a link to an evaluation survey. All participants filling out the survey will be automatically entered into a raffle for a $30 Walmart gift card. Our didactic today is on motivational interviewing for SUD, presented by Denise Beagley. Following that, we will discuss a case presented by Dr. Kapila Maramange. We will start with introductions, followed by didactics, Be Well program announcements, the case presentation, and open discussion. Thank you all for joining us at today's Echo. In the spirit of all teach, all learn, we look forward to learning alongside all of you and encourage you all to share your experiences, questions, and insight in today's conversation. And with that, we will do some introductions. Dr. King. You're muted.
All right, now I'm ready. So hello, everybody. I'm Van King. I'm a psychiatrist, professor here at UT San Antonio, and the medical director of Be Well Texas Clinic. Welcome. Glad to see you.
Thank you so much for joining us. Dr. Walker.
Good afternoon, everybody. Crystal Walker, PA with a doctorate, and I'm the director of medical services for MHMR of Tarrant County SUDS Division. Good afternoon.
Thank you so much for joining us. Denise.
Hi, I'm Denise Beagley. I have a master's in counseling psychology from Trinity College in Dublin, Ireland. I don't have an accent because I'm from San Francisco originally, so you'll get to know me a little bit more.
Thank you so much for joining us, Denise. Dr. Marambage. I hope I'm pronouncing it correctly.
Yeah, that's fine. Yeah, Kapila Marambage is my name, and I'm an addiction psychiatrist from UT Southwestern. I am the medical director for addictions at Parkland Hospital in Dallas. So I'll be presenting the short case on opioid use disorder today.
Thank you so much for joining us. And Dr. Kowalczyk.
Hi, I'm Alicia, Dr. Kowalczyk. I'm an addiction medicine, family medicine physician and faculty at Baylor College of Medicine, and a medical director of Santa Maria Hostel, which is a community residential substance use disorder treatment program for women in town. Thank you.
Thank you so much for joining us. And with that, we will move on to our didactics. Denise, whenever you're ready, you can take it away.
I will switch over here. I think I'm sharing my notes, no?
This is perfect. Yes, thank you.
Excellent. It's always a trip because I have so many. I could launch the space shuttle from all the monitors I have. So I don't have any disclosures, just I don't have a book or anything like that. I just use the work of Dr. William Miller and Dr. Stephen Rolnick, and I'm just happy, no relevant financial relationships to disclose. And just quick learning objectives. I know everybody probably, if like a show of response, how many of you have heard of motivational interviewing, used motivational interviewing? That this is a regular thing for you. Okay, excellent. All right, and a lot of times, so I'm going to talk about using motivational interviewing specifically for enhancing change with those individuals with substance use disorders. And so that's something that I think specifically, you know, it was originated, it was born out of working with people with alcohol addiction. And so it has a lot of different applications. So I teach police officers on it, paramedics, firefighters, across the whole spectrum of individuals, but it's always been rooted there in addictions therapies. And so substance use disorder now as it's termed. So when, you know, just to disclose all of these things, I call this my NASCAR slide. So I have many jobs. I can't give them up. I'm like a snowball. I keep picking them up. So I work for Banner University Health Plans. That's my main job. I've just been there. It's coming up on 2 years. I've been a crisis interventionist for a local fire department for 8 years. And I love that. Keeps me clinically based. And I teach at the Arizona State University School of Social Work. And then I have my own company. I started in 2020. That was a good year to start a business. All right. And then I put my Starbucks here because I used to be up to 8 Starbucks a day. So, and found myself at the age of 32 in a cardiologist's office. And he said, "You're awfully young to be here." And I was like, "Thank you." And he's like, "It's not a compliment. What are you doing?" So even though I teach about this, how many of us, I didn't go into Starbucks and order 8, right? It took a good 6 months. So how many of us have something in our own self that maybe we are aware of or we're not aware of? And so as we walk through, and I'm going to mention the stages of change, the trans-theoretical model, and how that kind of fits in with motivational interviewing. But I got to meet Dr. Miller several times, but he always wears a bolo tie. I like the fashion risk that he takes with any shirt, even a Hawaiian shirt. I love it. So that's me and him up in Flagstaff. So I'm going to talk about just right off the bat, communication styles. So there's 3 main communication styles and where motivational interviewing fits in. The following style, great Carl Rogers, you know, Dr. Rogers, he used to record his clients in 1942 and he would listen back. And that's how he kind of came up with his unconditional positive regard, not challenging or confronting his patients, but you know, allowing, just following where they were going. And so there's a bit of that we do in the work. If someone's telling us some news or they have grief and loss, we might listen and follow their lead. And then looking at the other side of that spectrum is directing style, teaching, instructing, leading, maybe telling somebody something. And that's where our writing reflex really lives, where we try to right people's wrongs. And particularly when it comes to substance use disorder, we have a tendency to be like, drugs are bad, you shouldn't do that, right? We kind of end up shoulding, or people get shoulding all the time. And if we could switch those shoulds to could, we offer choice. You could do this, right? So even a small word choice really kind of expands, where is this person coming from? And so where motivational interviewing lives is in the guiding style. We draw people out, and motivational interviewing is getting the person to see inside of themselves and encouraging and motivating them to making a change. It is not easy to stop using a drug when we know it's often rooted in some trauma, right? And so how do we help a person kind of see that? And we can't just tell them, but we got to draw it out. So just as a quick takeaway, the following style results in these things. We see it's more positive. It is very person-centered. The problem with it is it really doesn't, you could sit here for years with somebody, if you're just following them. There's, you're using reflective listening and all those things, and you're optimistic, but it may not get that person to see it as a short-term process. It might be a little longer. And then I always think about Dr. Phil when it comes to the directing style. Is that lifestyle working for you? You know how he yells at everybody and he tells people what to do, like quit using drugs, right? Well, it doesn't always work for everybody. And so you might end up getting what we call resistance, or in motivational interviewing talk, sustained talk. That person's going to be like, well, my use has nothing to do with anybody else in my family. And this is, like I said, where the writing reflex lives. So how many of you are familiar with the writing reflex? Do you feel like you have to tame that writing reflex down in yourself? I would love some sort of interaction from you. It's a lot easier if you don't resist me, right? In that sense. Let's have some fun. So this, usually we have great intention, right? We want to help people. We want to make things right for them. We want to fix their lives. How many of us do this in our private life, right? Versus our personal life? And the intent is really to be useful and helpful, but it's a strong desire within us, because if we're looking at where are we in the stages of change, we're in action, and we want the people we're helping to be in the same stage as us. They might be in pre-contemplation, they might be in contemplation, about 80%, right? It's an even split, they say, that either 40% of the population we work with doesn't realize and recognize there's an issue, or the other 40 is thinking about it, right? That's where ambivalence lives. So all of these things kind of come together when we're doing this work. And I have this little video, it's a short little video with Dr. Rolnick. It kind of just explains in about 1 minute and 56 seconds what motivational interviewing, that concept of the writing reflex. So I like to reconnect us with that and be more cognizant when we are working with folks, particularly with a substance use disorder, is there is that intent to really help right away. And maybe we need to have a conversation where we ask open questions, see what is their focus? Because I do a worksheet during one of my classes, and I say, what's something you've successfully changed in your life? What's something that you would like to change? And then what is something somebody else wants you to change? Do you think the thing that somebody else wants you to change and what you want to change usually matches? Most often not, right? We're a little bit of a, juxtaposition between those two. So here's a short video. I hope it plays well for you. Here we go.
I'd like to address this topic of the writing reflex, which is a term we developed to describe something we noticed outside of motivational interviewing in everyday life. Let's take the example of a mother who's trying to teach a kid to do a puzzle. Using the writing reflex, that mother will simply say, no, don't do this, do that. A problem is seen and the problem is solved for someone else automatically. The problem is that inhibits the learning of the child to solve the problem for themselves. As therapists and counselors, we can fall into precisely the same trap that mother did with her good intentions in trying to help a kid solve a puzzle. So faced with a client with multiple problems, given the reasons why we went into the helping professions in the first place, it's just a short step from solving the problem for the person. And that has two effects, which I'm sure you have noticed in your everyday practice. One is, if you like, it taints the relationship between the two of you. It doesn't make for a nice, constructive conversation, and it places a weight on you to solve problems for people, and they tend to shut down. The second can be observed in the behavior of your clients, which is that it doesn't lead to good outcomes. And there's reasonably solid research evidence to support that. This observation about the writing reflex provides one of the clear rationales for motivational interviewing. I'll add just one caveat here. That helpful spirit of yours, the use of that can be channeled into giving someone advice. And skillful advice giving is not the same thing as succumbing to the automatic unconscious use of the writing reflex. And how you give advice skillfully so that it's congruent with motivational interviewing, that's going to be an interesting topic, but it's not the same thing as the writing reflex.
Love his explanation, right? So I'm gonna be able to see the chat. That's one thing I can't see right now. So one skill that we need to have some practice in is letting go of the need to be right. And I think that is difficult because that skillful advice giving, we do have some knowledge to share. How do we kind of connect with a person and ask permission to share that information? If I just tell you, this is what you need to do, unsolicited advice actually breeds more, sustained talk or resistance. And so the skills of motivational interviewing are so important, bringing in that counseling rule, the 80-20. I always think when I work in crisis, it's more like a 90-10. People in crisis would like to be listened to, not talked at. And so is a person in crisis who's experiencing a substance use disorder, where are they? What do they want to talk about? And eventually you're going to get around to the topic of that's kind of brought them into your office, but it's done in a way where you've established some rapport and connection, and you're able to kind of broach that subject maybe a little bit differently than you would have been. So, and it also, even in small, brief interventions, this is useful. And it allows that person to feel empowered, to have some choice. And it really, I use it a lot of different ways. So I kind of bring in this traffic light directing style. It might be used if there's a direct threat, right? Impending threat, safety issue. I would bring, that directing style in. Following if there's maybe no threat and I just need to listen, grief. I do these things called death notifications in my crisis job, and I'm there just to really listen to the person. And then the guiding style is if I'm looking for some behavior change, the person tells me they want behavior change, they would love their life to be different, I'm going to really use these skills to enhance their motivation for changing. So I get inspired by kind of having this visual piece. Is motivational interviewing is really walking alongside the person that you're working with, instead of you leading them and telling them what they're going to enjoy on the hike or following behind them. And so it just inspired me to create this slide. So when we think about practical application, how do we bring this in? And I'm sure you all have things in your pocket that you kind of pull out that help a person. But if we were kind of inserting this into a conversation that we're having with somebody, just maybe consider, if you don't use these, maybe consider, this is directly from Miller and Rolnick's book, their 3rd edition. They have a new one coming out this summer. But identifying a feeling word. What are they saying? Are they struggling? Are they frustrated? Are they overwhelmed in their life? And what makes them want to change or stop using, or whatever the case may be? My favorite is number 3. What are the 3 best reasons to make this change? Because usually that's where the heart lives for them. They want to be a better parent. They want to be healthier. They want to live a long life. That's where the heart is, instead of us telling them where it should be in that sense. And, asking how important it is. Sometimes it might be really important, but they're low on ability or willingness to make change. So these are just some suggestions, and usually we kind of can play an exercise. I didn't know if I would have time, but maybe we can always click back to it. But this might be something, to explore and play. Miller and Rolnick say, don't do this like with your family, but I say do, but with informed consent. Say, I need to practice. Motivational interviewing is like a foreign language. If you don't use it, you lose it. And I just really try to encourage people to talk that talk, even when you're not at work, and it really comes out a different way. So these were real things I've heard from people when I've responded to calls. A paramedic once said, you didn't take anything like drugs or alcohol, right? And a guiding style on the flip side of this, right? Or you don't want to kill yourself, do you? I mean, who's going to say, oh yeah, I can't wait to share my feelings with this person, but you're feeling depressed, suicidal, perhaps, tell me more about that feeling. And so these are things that we try to encourage people, just changing small little tweaks to our language have positive outcomes. And that I always ask, what's the job of a referee? Kind of to keep the rules of the game, if there's any violation of that, versus being a coach. And that coach is to encourage, to improve player skills. And so if we can be more of an MI coach than a referee. I teach probation officers on this, and community correction staff as well. And that's a real shift for them, you know, from that policing aspect to now I'm going to be a supportive role for this person. And so we really do try to establish that working alliance or therapeutic relationship. And sometimes we just have a few minutes to do it. So motivational interviewing has been proven with many studies how beneficial it is, and just benefits for the population that we serve. Why am I, right? You already have amazing listening skills. We're looking for just small, maybe changes to our interactions with people. And using this MI guiding style really does increase behavior change. And so I often think if a person's in front of us, going back to the basics of Abraham Maslow from 1943, wrote in this paper, A Theory of Human Motivation, we look at what is at risk. And sometimes it's those basic risks, right? Those basic needs aren't being met for somebody. And how do we help that person? Right. So I like to connect, I like to hear their story, and then I like to offer some sort of help. You know, how do you see me helping you? Getting that person to tell me, or this is what the program can do for you. We can definitely set agendas and talk to people that way. So, and these are just small little changes to our language. It's really effective communication. I also teach verbal de-escalation skills, and MI is one of those ones that it naturally brings down that temperature in the room. And so that person almost feels it's a bit disarming because they're not, hey, this is not normal. Someone's not telling me what to do. We're paying attention. We're listening and hearing what they have to say. So in those stages of change, this is where that ambivalence really lives. And I kind of did a different spin on what the trans-theoretical model looks like. In that sense, that a honeycomb, it's really all over the place. We're probably used to seeing this in a circle, and it's not a linear process. And so people kind of pop in and out, right? Someone might be doing really well, and there's a reoccurrence that happens. And so, you know, how do we get them reconnected with that? How do we get them, you know, getting back onto their program and what they want? And I think that's important for us to consider. And we can activate our MI skills in each one of these stages. So Miller and Rolnick actually speak to this, that it's, Rolnick actually brought it into motivational interviewing in 1991 as a, you know, it's a way of kind of organizing where we're at with somebody. Miller, when I talk to him, he calls them the kissing cousins of motivational interviewing. It's a supplemental help. When we think about activating the skills of MI. But in a nutshell, we really want to get the person to talk themselves into changing, and how we do that, advanced communication skills, is using motivational interviewing. And so we have to use these skills in MI. It's not difficult stuff, but we've got to use it with intention. And so how do we can have a very different conversation if we're implementing these MI skills. So I know that's a lot of information in a short period of time. I have some books I would recommend. Again, new books are coming out. There's also a website I put there as well, has some great videos. I showed you one of them, but there's some other ones about lifting the burden. So motivational interviewing really lifts the burden off of you. I mean, how many of us have given people suggestions? Have you tried this? Have you tried that? And they bat them down. I've tried everything. And so it gets frustrating for you as the clinician. And so tell me the things that you've tried to quit using. And now we're getting the intel from them. And, you know, I might have some ideas. Are you open to hearing those? Right? Just shifting that kind of conversation to open it up really has, I think, positive effects. So any comments, questions so far? I know that, like I said, it was a lot of info and I somewhat stuck to the 20 minutes. Which is a challenge.
You did. Thank you so much, Denise. It was a great presentation. I will open up the floor for any questions or any comments or even your experiences with MI.
Mm-hmm.
I wanted to point out a comment that was in the chat from Lindsay, because I think it's a really good one to have a discussion with. She said that I have the writing reflex when I don't feel like I have the time to really be there with somebody. And I think a lot of clinicians may feel that same way, that it's just quicker to throw advice out there. So what would you say to that?
Yeah, that's excellent. Thank you, Dr. Walker. Yeah, I would. So even in a small little moment with somebody, we all know you have the knowledge, right? That's the reason why you're in the jobs that you're in. It's how do we take that and get the person to see it? So, you could even say in a short period of time with somebody, I have all these different ideas about what you could possibly do, but I want to hear what you feel like. Where are you at? And then maybe I'm going to share where I feel like, where I could be useful. And I think like that puzzle piece showed, if we just do it for them, we're not really teaching them how to fish in that sense, right? Or how to put the puzzle together. And so allowing that time for us to really know where they're at. And yes, that's the easy button to tell them what to do. I think it's more of the challenge for us to take a step back, see where they're really at, make that assessment, and then ask for permission to give them some information. And you'll find people are far more receptive. I mean, try this at home. I do it, like I'll ask my daughters, they're my Irish souvenirs, they were both born in Ireland, and I'll say something like, why didn't you empty the dishwasher? Like I do this as a test. And they're like, do you want me to fail out of school? And I'm like, wow, that accelerated quickly, so tell me about the obstacles you have that you're not able to unload the dishwasher. And then I make them laugh, and they're like, I can do it. It just takes a minute, So here, it's changing those behaviors, right? So when we look at it is easier, that is the easy button, but it doesn't mean that they're going to take the information. So just, this has been proven successful in 3 to 5 extra minutes. Doesn't take a long time, just a little bit. And even if you plant a seed, you can, going back, if they were coming back to meet you, Dr. Walker, what's still on your mind from the last time we met? Right? Oh, well, I was thinking about, you said last time that I could, just take small steps. I don't have to lose 50 pounds. I could just lose 5 and concentrate on that. And I've been trying to eat better and walk better. And, so just small little things. Great question. I saw that right when you mentioned it. Thank you.
Thank you so much. And maybe have a couple more minutes maybe for some comments or maybe challenges people have felt with MI.
Mhm.
What about when like when you're with your patients, right, and you have these small amounts of goals, would you recommend having an accountability partner for those goals? Like is that also like a additional part of MI that could be introduced, or is that like a core tenet of motivational interviewing?
Well, it certainly could. I like that. It certainly can help. So Miller and Rolnick talk about, the more you can get a client talking about their goal, the more likely they are to achieve it. And when we put it, like I always talk about getting it off your chest, when we feel better, right? So if I need a gym partner and I say, will you go with me to the gym? There's this accountability, right? I kind of see that person as a partner. There's hey, how many times I just want to sit on the couch and watch Netflix, or do I just get up and do the 30 minutes of exercise, right? Instead of extra fries, right? So I like that accountability partner in that sense. You could tie that in. You could even give information that's allowed in motivational interviewing, but I would still ask that permission in that sense. And I know that's hard sometimes, that here we have the information to share. You might even say some people choose to have an accountability partner. Have you ever heard of something like that? And then they could say yes or no, I don't know what that is. And now you have this opportunity to give a little information and say, people have said that that's helped them make the changes that they want in their life. And so you can that's still motivational interviewing adherent. and definitely a complement to the skills. And the reason why I talked about all the other communication styles is because we use them, you know, and that's why I say when you're using and activating motivational interviewing, you're going to do it with that intention. If you have the spirit of MI, you're coming across as you want to connect, you want to understand their story, and you want to offer help. That spirit is so important. That's half the battle of motivational interviewing. That was a great question. Thank you.
Thank you.
Thank you so much. And we'll move on now to our announcements. BeWell Texas is a welcoming environment with caring professionals who are ready to help people start or continue their journey towards recovery. BeWell Texas is committed to expanding equitable access to compassionate, evidence-based treatment and care for SUD throughout Texas. Next slide. Join us for the 5th annual Texas on March 27th and 28th here in San Antonio. It's a free event and includes complimentary continuing education credits. For more info, visit TxSUS.org. Next slide. Texas is also accepting exhibitor and sponsorship applications. 100% of the support that we receive helps in providing a free continuing education symposium for all attendees, fund travel grants for experts in the field, and underwrite other event-related costs. To learn more, visit TxSUS.org, and you'll find all the information there. Next slide. Our next TxRx Echo will be on Tuesday, March 21st. We will be talking about SUD in pregnant women, so please do join us. Next slide. We now have an easier, more efficient system to claim CEs at all our Echo sessions. All you have to do is text the code we are dropping in the chat as we speak to the number above. You will receive a text confirming that your continuing education credit is ready for retrieval. Please make sure that you text this code by midnight today. For more information, you may email at bwelltx@utisca.edu. And now we will move on to our case presentation. Dr. Marambage, once Echo IT shares the case, please take it away. Thank you.
Yeah, thank you. Can I share my slides? Share? Oh, no.
We typically walk through the case.
Okay, sure.
Was there a different information on your slides?
It's fine. We can, yeah, I think there is more information, but I can go through this one also. So we had a case, I wanted to discuss a case of opioid use disorder. You know what? Is it better if I share my slide? Is it okay for me to share my slides?
Sure, you can.
Yeah.
Dr. Marambagi, with just so you know, with the case form,
Yeah.
the case form is what we use with our
sure.
participants. So
No problem. No problem.
the case
So let
form is
me,
enough for us to get the information. And then if you want to, we'll move it up and down if you want to, so you can see more info on the form.
okay, fine. Yeah, please show the form then.
Sure.
I'm sorry. Okay,
Thank
so
you.
it's an opioid use disorder case. I will go through the case real fast. It was a 26-year-old female who came in with a left lateral thigh redness and swelling and fever. It was diagnosed to be an abscess and cellulitis, and the patient was subsequently admitted for IV antibiotic treatment. And the patient revealed that she has been using black tar heroin intravenously or via skin popping. And the last use was about 3 days ago. So the patient had opioid withdrawal at the time of presentation. And that included, body aches, chills, diffuse aching, muscle cramps, stomach cramps, yawning, dilated pupils, etc. And the patient was significantly irritable at that time. And the past history revealed that she was using heroin for about 10 years. Her boyfriend has introduced her to intravenous heroin. Now she wants to quit. And she also concurrently uses cocaine for speedballing, and which is a combination of cocaine and heroin. And the tolerance has increased over time over the last 10 years, and she has at least overdosed at least one time before. And she has a history of sexual trauma as a child, and also some self-injurious behavior and prior suicide attempts, at least 2 in the past. Some psychiatric hospitalizations also in the past. So we diagnosed a case of opioid use disorder severe because she has had a problematic pattern of use. She has had desire and unsuccessful, efforts to cut down or stop. And she has had significant failures to fulfill her roles and obligations. She has lost her job. She has had legal issues. Now she's ended up with a medical issue, which is this abscess due to the skin popping business that she's been doing recently. And she has been using in physically hazardous situations, and now she's in withdrawal. So all those criteria put together met the DSM-5 criteria for opioid use disorder severe. And then I wanted to talk a little bit about the black tar heroin that she was using, and that is the most prevalent type of heroin that we have here in Dallas. I'm sure pretty sure in San Antonio also, and most parts of Texas. And what the thing about black tar heroin is that it can cause venous sclerosis. So generally, people will start using intravenously and very fast. The black tar causes something called venous sclerosis, which is the collapse of the veins that is due to a substance called the 6-monoacetylcholine in black tar. So as a result, pretty soon the people will lose venous access to be able to, administer heroin intravenously. And then what they will do is they will start this process called skin popping, where they will either muscle it onto a muscle or a soft tissue or something like that. And the risk in that is that the black tar heroin has a lot of gram-negative, organisms, especially Clostridium perfringens and botulinum. So it causes necrotizing fasciitis. And then this is the kind of reason why the patients develop abscesses and heavy soft tissue infections. So that's the situation with this patient also. So most of the time, these patients need long-term antibiotics, and therefore they need opiate, withdrawal managed. So in this case, how we managed the case was starting the patient on a buprenorphine induction, and then went on to maintenance. So what we generally do is we measure the cow scale to see whether the patient is adequately in withdrawal. And if so, we will start 4 milligrams of buprenorphine, followed by another 4 milligrams, and then keep the patient on 4 milligrams BID at first, that is twice a day, and then we revert to 8 milligrams daily. Now, in some cases, when we are suspicious that the patient might have used fentanyl also, which is a long-acting opiate, we sometimes use Sofran, which is an antiemetic, which is going to prevent the patient from throwing up and prevent any precipitated withdrawal. And that way we induce the patient and maintain. So in some cases, the patients do not want to be on Suboxone or buprenorphine, and then we start the patient on methadone. And in both cases, we check the cow scale and check whether the patient is in adequate withdrawal. Of course, for methadone, it doesn't matter. But in the case of Suboxone, you need to have the patient in moderate to severe withdrawal in order to prevent any worsening of the withdrawal symptoms. So methadone, we have a cap of about 40 milligrams on a daily basis, and we give it in divided doses. So in both cases, we refer the patients to outpatient. We give them a referral appointment in a place where they can continue either buprenorphine or methadone. Very minority of cases will not want to be on maintenance and want to be on only detox. In such cases, we will do the detox, but we prefer the patients go into maintenance. And the maintenance treatment will happen in a clinic. So in addition to that, we do a certain other brief interventions, both inside the hospital setting itself, where we are an inpatient consultation team. So we do some interventions in the hospital during the time that they are with us, especially those patients who are on IV antibiotics who are going to be with us for several days. Then we get more chance to see them, and our therapists will be able to see them, social workers and peer navigators. So we have different brief interventions, therapy interventions that we might do while the patient is also on the buprenorphine just like in this case. And also, if the patient were to be admitted to our clinic, then we will continue those therapeutic methods. And I want to briefly go into the therapies that we might use in the inpatient outpatient setting. One of the therapies, the most prevalent one that we will use, is the motivational interviewing, on which we had a great lecture today. So we will ensure the patient's autonomy. We will consider the change versus sustain kind of talk and readiness for change, and then plan move forward. I will not elaborate on that, but we will do motivational interviewing interventions during the time. And then also we will educate the patient along CBT interventions, cognitive behavioral therapy, where we will discuss with the patient and help them understand the high risk situations versus low risk situations that happen in their lives, and talk about cognitive distortions they have about drugs, like, for example, that medication is a replacement drug or something like that, or the rationale to use and the kind of hopelessness that leads them to use drugs. These are CBT interventions. And we will look into skills deficits in the patient and try to rectify some of those things and work with the patient on those, and then get into normal life skills and goal setting deficits. If they are identified, we will address them. These are all CBT. And in dialectical behavioral therapy, which was kind of useful in this particular patient, in that she had some cluster B personality traits as well. So we will talk about things like dialectical abstinence, where we will consider both the relapse risk versus, and also the obsession to use versus the obsession about being sober, and then build like an integrated rational mind, where there is abstinent mindset built, and then also try to build new bridges and burn old dysfunctional bridges, and also to go into harm reduction and mindfulness, and urge surfing through mindfulness, how to manage urges through mindfulness. And then the last thing that we consider is seeking safety, which is a module for post-traumatic stress disorder trauma ridden patients. So to co-manage PTSD and substance use disorder, this particular patient also had significant trauma history. So seeking safety is safety from substances, safety from dangerous relationships, safety from extreme symptoms such as dissociation and self-harm, safe coping skills, safe identify stages of danger and safe contacts, interpersonal topics, how to stay safe within interpersonal dealings, and introduction to case management. So these are all seeking safety. So we have therapeutic methods, CBT, DBT, motivation interviewing, and seeking safety. And then we do inductions, buprenorphine and methadone. In this particular patient's case, the patient was referred to our clinic, where she is currently on buprenorphine maintenance. So that's the brief case that I have for you.
I apologize. Thank you so much for the case. An excellent presentation. I will open up the floor for any questions or comments.
Yeah, it's very nice. Thank you. So how much of this this counseling treatment is available while they're in the hospital?
Yeah, good question. So most of the time, as I said, we are banking on the hospital patients. We don't have any beds of our own. We don't have detox beds or addiction beds in the hospital, but we serve like a 900 bed hospital facility, of which we serve about 600 beds, I would say. And then whenever they get admitted for medical reasons, until they are medically cleared and ready for discharge, we get a good chunk of time, if we are lucky, like at least 3-4 days. And we see them on a daily basis during the weekdays. So I would say we get at least 2 to 3 sessions. And my team has a psychologist as well as 3 social workers and a peer navigator. So they divide the work among themselves. So I would say on average, they would get about at least 2 sessions apart from the initial evaluation. So we are able to most of the time engage MI through MI, but sometimes we are able to do other modes of treatment as well.
Huh. So you have some dedicated employees that are able to sort of round in the hospital on the different patients that sort of like a part of a consult service? Is that the way it works?
Yeah, I run a consult service. So my team comprises of myself and a nurse practitioner and two psychologists who are rotating at a given time, one and then one or two pharmacists, three social workers and one peer navigator. So it's a big team plus residents, fellows. So among us, we can divide the work and, each person can go and engage with these patients. I've been running that consultation liaison addiction team for the last 4 years.
Sounds like you have a very big outpatient program to accommodate this as well.
Yeah, so we started an outpatient program which runs 1.5 days a week. So we absorb most of our patients, but at the park, in the Parkland sitting, we need to have some kind of coverage, either at least Parkland insurance. If not, then we will refer them to our other programs in Dallas to continue the treatment. But we have a big program. In the program itself, the same staff will go and run the program. We have groups and individual therapy as well as medication management, psychology too.
And is this a psychiatry service or a medicine service?
No, this is a psychiatry service. I'm an addiction psychiatrist. So this is all psychiatry. So it's not only opiates. We use alcohol. We do alcohol, any substance. We do detoxes for all different substances. So all kind of patients come to us, and then we do dual diagnosis also because we are psychiatry.
Nice. Very robust, it seems.
Yeah, we like to think about it that way. Yes, it's pretty good.
Anything in particular unusual about this patient? This seems like a pretty bread and butter patient for your service.
Yeah, it's nothing unusual. It's a pretty bread and butter. Only thing I wanted to convey was this black tar heroin. You know how I'm sure Dr. King must be very familiar, most of the other providers too. But, I came from the East Coast. I used to work in New York, New Jersey. I didn't know what black tar was until I came to Dallas. So in New York, New Jersey, it's white powdered China heroin, where the highest risk is HIV and, overdose death and all that kind of thing. We didn't have this epidemic of, soft tissue infections or deep tissue infections. So after I came to Dallas only that I realized here the HIV and the hepatitis C somehow is not as bad as there, I would say, because of the process that it takes to make the black tar heroin. It probably destroys the HIV virus, but we have severe bacterial infections here, and it was less overdose deaths until the fentanyl came. Now we have OD deaths also because of fentanyl. So
does the fentanyl get mixed in with the black tar, or do they take? Yeah, I see.
Yeah, absolutely. It gets mixed with the black tar. And it comes on its own also, I have noted now. And, some of the opiate pills that they manufacture, even the oxycodones, they somehow mix the fentanyl into that as well, it looks. And it's a big problem because, we cannot initiate the buprenorphine easy because most of the patients are kind of in the withdrawal, but still the fentanyl lingers in the system. So they run into precipitated. The main thing about the case that I wanted to convey, I guess, if you want to know something special, is the black tar, that how it all impacts, how it changes the whole game.
That was something I was fascinated with. Has she been using black tar for 10 years?
Not really, no. Initially, she was using something called cheese, which is like, white heroin, black tar heroin actually, but it is with Tylenol. So she was sniffing it. But the black tar heroin, I skipped that part. The boyfriend that I mentioned came into her life about 2 years ago. So that person is the one who escalated it to IV use and subsequently black tar and, intramuscular use.
Yeah,
she used to be she used to run an apartment complex, apartment manager. She used to be, high functioning. And now suddenly she's kind of almost homeless and it's bad.
Yeah. And the fact that she wanted she wanted help to get off of it, which is great, right? Like, because if you're looking at those stages of change, she's ready. But then how do you kind of encase all that for her? And it's multiple areas, which is, it sounds like your team kind of attacks it from all holistic approach, which is fantastic.
Yeah, very good point, Dr. Beagley. So yeah, that's true. A lot of people, like you mentioned, I like the fact that you put it in a like not a circle, these stages of changes, because I also completely agree with that. They go in and out of this. So sometimes people will beg us to they want help. But the moment they get out of the hospital, it's a whole different game. The stages of change, has suddenly dropped to something else. So our attempt is to, the reason why we do all those therapies is to establish that this is something we can do. These are the things that you will get in outpatient, and also to give a script, even a bridging script until the appointment, so that there's no risk of them relapsing in middle, and also giving them a form handoff where they will definitely have an appointment. You have any little space, they will fall through the cracks, I would say. So although they look very nice on paper and the way that they beg and all that, as soon as they get out, things change sometimes.
I'm sorry, I forgot now. Did this lady go on Suboxone maintenance?
Yes, she did. She did go on.
Did she follow up? Do you know?
Yeah, she's with us right now in the clinic. So that is also one significant point.
Okay.
So once we are able to get people into our clinic, we have our team like peer navigators who are drug use. I mean, they've had a history of drug use. I'm sure you know what I'm talking about, and they will keep a tab on them. So it is difficult to escape. They're like case management. They will keep calling and they will get them to the clinic most of the time. Otherwise, if you leave them alone, what we have found is about 60% will drop. Honestly, even if you give an appointment, only 40% will show up. 30-40%.
Have you always worked with the peer managers or the peer navigators, or had you had experience, before the peer coaches and afterwards? I'm just wondering if you have an impression of how much improvement you get with those guys.
Oh, I absolutely love them, because I used to work with them in New Jersey. That's the whole thing. And of course, when I came to Texas, they already had some peer navigators before I even came. So they were only working in the emergency department. So I absorbed some of them, and now I'm in the process of absorbing the whole, peer navigator section to my team under me, so that we can operate together. They're absolutely great. They talk a different language. They relate to the patients better. I'm sure Dr. Beagley knows what I'm talking about, in that they can connect with the patient, because they have been there, done it, and they've been sober for 20 years. That is very encouraging. Their dialogue is very different. Their experience with Alcoholics Anonymous and 12 steps is different. So I really value their presence in the team. I have gotten a grant so that I can keep one of them with me permanently. So, and she's wonderful.
Yeah, peer navigators are like secret weapons, right? They're able to connect, like you said, in a whole different way. And I always also explain to people, it's taken time for you to get here. It's going to take time to heal too. And I love that you bring in that trauma-informed care lens as well, and that response. How do we respond to people who have, no one just says, hey, it's Tuesday, I'm going to start smoking meth or using heroin. There's a reason. And we can kind of address that concurrently with the other, support. Yeah. We're going to handle this on a medical side, plus on your life side, so.
Exactly. And one of the things I didn't mention in that is acceptance and commitment therapy, which is wonderful. And I'm sure Dr. Beagley knows this. And it is one of the best things that we use in the clinic itself. So we have all modes of therapy. It's incorporated into our program. And then we try to do our best in the inpatient setting with the limited time, though.
So there is
a question in chat. Sorry.
Yeah, no, go ahead, Alicia. I was going to read the question from the chat. You take it away.
It's fine. So from Jordan Scott, apologies if answered, and I don't think it has been, Jordan. Is there a plan to provide her with safer use supplies, or at least tips for safer use upon discharge? So again, getting that harm reduction. If she does have a slip or a full-blown relapse, any opiate overdose education, naloxone distribution would probably be wise too. So just if you could comment on what you do, that would be great.
Yeah, so harm reduction wise, in the case of opiate use disorder, the only big thing that we do is we dispense naloxone at least 2 vials at a time every 6 months to all patients that are on opiate pain medication as well as Suboxone. So there is a navigator that like a dashboard that will monitor all that. So that is one thing we do. And of course, the second thing is that whenever there are many people who kind of have lapses or relapses or something, but we never kick them out of our clinic. Sometimes they will have concurrent use of methamphetamine. Now, in this patient's case, she uses cocaine. So whenever something like that happens, we do urine drug screens, but I maintain an environment where the patient is able to tell us beforehand, even before the urine drug. It's not like we're going to catch you or something. And then we work through that so that, we can get rid of the additional problems or whatnot. And in the case of alcohol use disorder harm reduction, yes, we will sometimes go into safe drinking limits and, that kind of things. But we do our best. We like harm reduction. We are not expecting everybody to be 100% sober. And in the DBT module also, we consider that there might be relapse, there might be sobriety. So we work on those dialectics. So we are tolerant of a lapse. But if it goes a little over the top, then we will try to get them back on track. We never fire anybody for having relapse. We understand it's a disease.
It's part of the process, the treatment, isn't it? Yeah. I love that it's not adversarial for them. It's just part of the process. Thank you.
Yeah, in fact, we like to kind of we encourage them. I mean, we praise them for admitting what they did. And my patients will tell me like that I used a couple of oxys, something like that. So we'll figure it out, and we give more therapy. We give a little more. It's not punitive at all. We are trying to bring in contingency management also for cocaine and all that. So we're trying to do our best, but it's tough though.
I think I work with, like I said, probation a lot, and when we can look at the levels when they do the UAs, we can see that they're using less. So it's almost like that harm reduction. And I always say it's best if they can tell me they used rather than a test. If they share with me, that's also another level of connection with the patients. So
I agree fully. Yes.
Thank you so much. This has been a wonderful discussion. Dr. King, if you could please summarize some of the key points from today's discussion.
Well, we heard a very interesting case, and not untypical, I would guess, for many presentations in hospitals, people using intravenous drugs and then having abscesses. We heard a little bit about the particular dangers of black tar heroin in this regard and how it's associated with more of these abscesses and infectious complications in folks, and how really I haven't heard of a better consult service than what our presenter here was telling us about today, in terms of trying to get as much sort of psychosocial support and guidance while they're with us inpatient, and then a smooth transition to an outpatient treatment, including using the peer network, which I not only hear, but in many places we hear how that really does help to engage the patients in ways that professionals sometimes struggle with. So a very nice case to discuss today. And she's still in treatment, so that's a great thing. So hopefully she can get back up to functioning to her prior good level.
Thank you so much, Dr. King, and thank you everyone for joining today's session. This was a very interesting session and great discussion today. As a reminder, to earn C credits, please text the activity code 1009-2713 to 844-502-1338. And please do that by midnight today. We also request you to complete the post-session feedback survey using the link in the chat. The survey link will be open for 1 week. If you would like to present a case, please email bwelltx@utisca.edu. We look forward to seeing you at our next session in April. Have a wonderful rest of your day. In March, sorry, I skipped a month. In March. Thank you so much. Have a good one.